It would be different for the president of AIOS. It would be different for chairman AIOC. So everybody has his own way of guessing or gauging what is success. Practice the way you interact with your patients, who are the most important people, to interact with your staff, who are the next most important people. Rest all the people, your own family, they are equally important. For your society, what is your contribution to the society? We all hear a lot of good things, big things. We have heard JFK saying what you have done for the society. And recently Mr. Rahul Gandhi quoted what somebody asked him about the question, and he said what you have done for the society. My point is, what is our contribution to AIOS? What are we doing for AIOS? We keep on writing a lot of mails. I myself have written a lot of mails to Sir, to Dr. Ramamurthy. What is our contribution? What are we doing for the society? Okay, forget about society. What are we doing for the fellow ophthalmologist? What have we contributed? Why should we think about it? Because we have to be a good person. We have to understand that the whole premise of this life is not only about ourselves, it is about the people you live. You do so much for the patients, not that your contribution is any less, but what are we doing for our fellow ophthalmologists? And then how can you make a difference? How can you make a difference? So if you feel that you have to make a difference, what difference can you make? In the clinical practice, these are things I wanted to take up, but Sir has already told a lot in detail. Insurance, helping society, group practice, corporates are coming. What is your standing? How are you going to be a part of corporate or doing corporate practice, or how you are going to do a group practice? These are bigger questions. We have to go through all this. We have to participate, be a part of it. And only then we can say, okay, this is a group practice we have to do. And next important thing is, this. A lot of people publish that as research and newer things. But very few people, when we talk, we say a lot of things. How many of us will go through these things? How many people are helping the upcoming ophthalmologists? We have to see that these people who are upcoming, the residents, the juniors who are coming up into practice, these are the people who would be face of ophthalmology once we are seniors or once we leave the stage. So what are we doing for them? Not as president of AIOS, not as a chairman AIOC, as a simple ophthalmologist without any post, as a private practitioner, as a person who practices in an institute. So the point at the end is, we all should be together. There could be small groups and bigger groups, but at the end of the day, we are into AIOS. We should always have positive influence on each other. Life is so short, we don't have to have any negativity. We should, as Dr. Natarajan rightly said, we should imbibe positive things. Preferred practice patterns. Among ourselves, we can make our own preferred way of practicing. And this is a very great thing that AIOS has come up. Patient information system, not necessarily patient counseling, but patient information system, which means what went wrong when we did something, and then what we want to do. All this is okay. We want to do good things. We want to help juniors. We want to do good things in the society. So first we have to find out what we want to do. And then we have to find out how we can do that, get like-minded people, and try to change the system for betterment. Everybody wants to change the system. There will be a lot of people who would want to change the system because change has to come. But it should be for the betterment. And there is always a scope for improvement. So nothing is final. We have to involve people. That is the most important thing. Together you can make a difference. And another important thing is, when we want to make a difference, when we want to change something, we have to be patient with that. You cannot, you just cannot say that, oh, I have said the AIOS to sunta nahi hai, humne to ek letter likh diya, we have written that nothing has happened. It takes time. It takes time. All the people are ophthalmologists. All the people have brains. They are all equal. They are good. They are intelligent. They know what you have written. It takes time. So we have to be patient. We have to talk about it. We have to get our point inside that people need time and try to see other person's opinion. There are different viewpoints for the same thing. So it is important to give space to others to take their opinion and then move forward. So differences are always there. We have to make sure that they are made to work in a positive fashion. And so I end with the note, together we can and we will make a difference. Thank you so much. Thank you.
Thank you. Actually, we have seriously take up and we will try to incorporate. Teamwork is one thing. Anyhow, AIOC, at least the governing council is working as a team, and both outgoing and incoming people are also work as a team. That is very good. And the members will always be in positive hearing more to take everyone's opinion, and even any small member or big member expresses this thing through a letter. We are taking up, and you have seen yesterday GBM also we have discussed threadbare about it. Thank you, Jitani, and do well in future. Function, that is the certificate distribution for the candidates who have undergone the program, and they express that there is some contribution has come to them, and they are trying to change, and change will not make all of a sudden. Okay. I would call upon Professor Antamanda, outgoing president of AIOC, to give away the certificates. I call Dr. Rahul Shukla to take his certificate from Professor Antamanda. Rahul is so impressed with the program that he recommended his brother to be in the program. His name is Himanshu Shukla. Right now taking the photograph. Male gender, it is female gender also take the leadership positions and programs.
What do you mean by that?
See, so two ladies in the leadership position.
Gender bias. You have got the wrong person.
Gender prominence I am showing.
Yes.
It is not gender bias.
Males are not in the picture.
Yes, that's what. All the best. Kapil Kumar, can we pass on? Anyone knows?
Anyone knows Abhijit?
Prem Tanwar. I request Partha to come out. I want to introduce the new chairman ARC, Dr. Partha Biswas. He is very inspiring and capable personality as such, and he is taking reins from me. Last 3 years I have conducted, and he will continue the whole sentiments as well as the functioning of ARC much more effectively than me, because he is more smarter than me. So, yeah, more important. Yeah. And I want to promise in front of all of you that whatever helping ARC much more stronger, because last 3 years, before last my term, ARC was not viewed as a post that can be really potentially someone can take. So that's where we have brought it. Great. But I request Partha to make it much more higher position, so that people of members of AIOC should see ARC is the most potential position in the AIOC among all the positions. With this, I would like to thank all the GC members of ARC and the AIOC, and all the members of AIOC for giving me this term to serve the AIOC. Yeah, Dr. Partha, what is it?
Over, and today it's been a learning and experience for me as well. The talks I've heard Dr. Ashok Grover speak, Dr. Natarajan speak, I'm inspired by them. I've heard Ajit speak and Professor Panda also. But today I heard Rahul speak and I heard Jitendra speak, and it was inspiring. I'm inspired by you. Thank you very much, and what a great program the LDP program is. We definitely need to do so many things. The inputs from everybody is so important, and I would like every one of you who have trained in LDP to transmit that same feeling amongst each of your people in the neighboring areas. So with this, I thank Ajit. Ajit has been a real dear friend. In fact, all 4 of us, or 5 of us, who have been there in the frame. And this process of electioneering has been a very, very fine process, a very process filled with a lot of friendship. Ajit is a great friend, and all the others are great friends, and I would look up to all of them to help everything develop in academic and research. Thank you very much. Thank you.
Thanks with an appreciation for the great work done by Dr. Ajit.
All the LDP members, I request you to correct the books given by Dr. Nataraj.
Minding you.
We'll give you later.
Gangadhar Reddy from Hyderabad. Former Director of Sarojini Devi Eye Hospital Institute of Ophthalmology. To help me here with the session is Dr. B. Ganesh here, and Dr. Sachit Sinha is not available here. And we have got 14 speakers altogether in this session. And Hyde Park is a concept where within a space of 4 to 5 minutes, all of you are going to express your views briefly in a very short span of time, boldly and fearlessly. No questions asked, but with the permission of the chair, if anybody wants to ask just one question or two, you're welcome. And we go ahead. Is there a child among the audience? Okay. Then the child is free to express his opinions and her opinions and tell the whole world about what she thinks about the world. Chief author is Dr. Jyoti Matalia, and the presenting author is Nirupama Kasturi, to speak on the outcomes of lensectomy in a series of children with ectopialysis. Speaker here? Not yet? Okay, we'll go to the next speaker and wait for the first speaker in case it turns a little later. Assessment of causes of low vision and acceptability of the low vision aids in the pediatric population in our setup. Chief and presenting author is Dr. Pooja Aditi Dubey. Okay.
To present my paper on assessment of causes of low vision and acceptability of the low vision aids in the pediatric population in our setup. At the outset, I would like to clarify that the authors have no financial interest in this project. Low vision, as defined by the Bangkok definition, is a person with low vision is one who has impairment of visual functioning even or a visual field less than 10 degrees from the point of fixation, but who uses or is potentially able to use vision for the planning and or execution of a task. So various studies conducted all over India have shown the prevalence of low vision in children from 1% in Delhi to 1.25 in 1,000 children in Andhra Pradesh. So severe vision loss in early childhood not only adversely affects development, mobility, in low vision, and find the determinants of low vision and preference of type of low vision aids in our setup. This is a prospective interventional case series of 20 patients from May 2011 to December 2012. Out of 32 consecutive children presenting to the clinic, we selected 20 children based on the visual acuity less than 6/18 and who were able to comprehend the questionnaire. The bilaterally peer-denied patients or patients with more than one contributing disease or with central media opacity or associated comorbidities which will limit the use of a visual aid were excluded. Thorough history and clinical examination were done to ascertain the cause of the low vision, and best corrected visual acuity were given by refraction, and after considering that these patients had low vision, a trial of low vision optical device or a non-optical intervention was prescribed, and a functional vision questionnaire was administered to the children prior to the prescription of aid and after 3 months of the use of the aid. These are the few examples of the children being given trial of visual aids. We observed that the age range was 6 to 18 years with a mean of 11 years of a patient. Degenerative myopia and hereditary macular dystrophies and retinitis pigmentosa were the most common causes, and the patients were mostly of male gender. The type of LV used where only optical aid was used in 2 patients and non-optical modification only were used in 8 patients, where optical along with non-optical modification were used in 10 patients, and most of the children required a near visual aid. But non-optical modifications which are simple can be made at home, and economical modifications like better lighting, sitting close to blackboard or holding reading matter close to the eye, or filters or typographs or writing guides were more used in almost 18 children. And pre and post visual rehabilitation score had a significant difference between the pre-administration of the visual aid and the post 3-month post prescription of the aid. So in our setup, the majority of the causes of low vision are due to retinal diseases, which is in accordance to the AEP test, the Andhra Pradesh IBC study. But some other observers had reported as congenital eye anomalies as a major cause, but it was not found in our case. And 55% of the patients were male, which could be due to the bias in healthcare seeking behavior in our setup. There is a scarcity of data comparing optical low vision devices with non-optical interventions. We found out majority of the children needed non-optical modification, either in conjunction with the optical device or on its own. Overall, there was a significant improvement in 3 and 3-month post-op rehabilitation visual function scores. So I conclude that with proper training, children with low vision can use their residual vision to improve their vision-related quality of life. And often simple non-optical modification can help where complex optical devices are not accepted or are not affordable. Thank you.
Now we'll move on to the next one. Micrography as a tool in detection of evaporative dry eye in diabetes and non-diabetic. Presenting author is Dr. Lieutenant Colonel Mrs. Cynthia.
Good morning. Today my topic is micrography or microscopy as a tool in the detection of evaporative dry eye. So dry eye is a multifactorial disease of tears and ocular surface that results in the symptoms of discomfort, visual disturbance and tear film instability with potential damage to the ocular surface. It is accompanied. There are 2 major idiopathogenic types of dry eye, that's aqueous deficient and evaporative. The prevalence of diabetes mellitus in India is 12 to 15%, and in India it is estimated that 79.4 million people will be suffering from diabetes by the year 2030, and dry eye is more common in diabetics, that is 50% more common in diabetics than in non-diabetics. This is the dry eye grading microscopy or microscopy as a tool in the evaluation of evaporative dry eye in diabetics and non-diabetics. The study design is a prospective, non-interventional, cross-sectional case control study. It was done over a period of 2 years, and it included 100 diabetic and 100 non-diabetic patients, and ethical clearance was obtained and informed consent was taken. The inclusion criteria was known patients of diabetes and non-diabetic patients having symptoms suggestive of dry eye. The diabetic state was determined according to American Diabetes Association guidelines. History of medication for diabetes, RBS more than 200, HbA1c more than 6.5% and FBS more than 126 mg per deciliter. The exclusion criteria was patients having ocular disorder known to produce dry eye, such as pterygium, systemic disorders associated with dry eye other than diabetes like thyroid-associated orbitopathy, and patients on any drug treatment which produce dry eye, or patients who have undergone any ocular lid or refractive surgery. So the methodology, after taking a detailed history and general physical examination, ophthalmic examination included Schirmer's, T-Bud, lissamine, fluorescein staining and clinical microscopy. The microscopy is an estimate of dropout rate of patients' microbial glands by transillumination, and micrography implies photographic documentation, and a count of 24 per lower lid was taken normal. So the scoring of each eyelid was taken as follows, that is 0 included no gland dropout, grade 1 that is gland dropout in less than half of the inferior tarsus, and grade 2 that is gland dropout in more than half of the inferior tarsus. So So the results, that is, out of 200 patients, 116 were males and 84 were females between the age group of 40 to 65 years. The mean age group in non-diabetes was 52.36 and in diabetic was 52.43. This is the chart showing the meibomian gland dropout. It shows that there is significantly more dropout in diabetics than in non-diabetics. And the frequency of dry eye disease in diabetics and non-diabetics with or without meibomian gland dropout. So the dry eye disease with meibomian gland dropout was more in diabetics than in non-diabetics. And this is the graphical representation. So the sensitivity and specificity of meiboscopy in dry eye disease, it is comparatively more in non-diabetics and the sensitivity and specificity is more in non-diabetics than in diabetics. And the positive predictive value is more of meiboscopy is more in diabetics and the negative predictive value is more in non-diabetics. So therefore I conclude by saying that the high specificity and the negative predictive value in non-diabetics shows that the clinical meiboscopy should be included in the staging of dry eye disease. The limitations of my study was a larger sample size in both the groups should have a more representative and reproducible result. These are my references. Thank you.
Thank you, Dr. Nitya. Any questions?
Most of us miss the tear film, and in particular the meibomian glands. Yes, as individual practitioners, you may have meiboscopy or you can do a meibography, but then one ought to definitely look at the high magnification on the meibomian glands to assess the function and then proceed. Thank you.
Next study of the tear films and secretion of pterygium patients, diabetic and non-diabetics. Dr. Ashutosh Ganeshwari, here? He's here. Get a little closer to the mic.
Pterygium is a degenerative condition resulting in the formation of fibrovascular wing-shaped tissue that develops from conjunctiva and encloses water quality. UV A and UVB rays are also important, and local causes of dry tear film of the most lipid in the most useful and vitamin occurs. Researchers have documented various local manifestations of diabetes to include large fluctuation of refraction, premature cataract, changes in PDR and PDR. There are also many diabetic patients complaining of blurring of burning of eyes and dryness associated with foreign body sensation. Diabetic increases with age and duration of diabetes. The longer the duration of the diabetes, the higher the incidence. The aim of the study was to compare Schimmer's test and tear film recurrent as diagnostic utility to detect tear film abnormalities in pterygium patients having diabetes versus non-diabetes. Ours was a prospective study for duration of 1 year with samples of 62 patients, which included 26 females and 36 males. Inclusion criteria were diabetic patients for case study and the non-diabetic control. Exclusion criteria were all factors which may affect the pterygium stability, tear film stability, local and systemic factors. The method of collection of data or staging was done according to the previous classification in the previous papers done by various authors. In the exposure situation, according to occupation, was done for the pterygium patients. The test for significance for association was done by Pearson's chi-square test and p-value less than 0.5 is significant. T-duty time test and Schimmer's test were performed and the grading was done accordingly. According to our case data, 62 patients, 14 bilateral section, 48 had unilateral, 34 cases right and remaining at left hand. Out of 62 patients, 26 were females and 36 were males. Of the diabetic patients, 14 female patients were diabetic and 17 male patients were diabetic patients. Fourth and fifth decade dominated in our study, and there was a significant difference in the grading and staging of the pterygium patients in our study. Most common presenting symptoms were burning of vision, burning sensation, grittiness, redness, followed by heavy sensation. Of the diabetic patients, incident finding was 3 male and 5 female patients that presented with diabetic retinopathy. Now comparing with the TBUT test in group A, maximum patients, that is 15, presented with unstable tear film, followed by 13 patients of borderline tear film and 3 patients of normal tear film. And in group B, that is a control group, only 4 patients were presented with unstable tear film, followed by 7 patients of borderline, and maximum, that is 24 normal tear film. When you compare both the groups graphically, the trending was towards unstable TFM for the group, that is diabetic patients, and for the non-diabetic patients was towards the normal TFM, which was significant in both, comparatively. Now when we compared the Schirmer's test, the values were noted down. The mean Schirmer's test 1 value in the diabetic patients was 13.64 mm, that was non-diabetic was 17.63, and for Schirmer's 2 it was 11.23 mm in diabetic and 14.51 mm in non-diabetic, which was statistically significant. In exposure situations were also comparatively not very significant. A review of literature has shown that so far no other studies have been done to show a relationship between diabetes dry eye and pterygium unequally. Now, in present study, males were more affected than females, but in regarding to pterygium, but when in regarding to diabetes, females were more affected. In another study, the similar findings were there in the pterygium patients were found, which were in accordance with our study, and the paper were. In another paper, TBO2 was significantly lower in diabetic patients as compared to the controls. We also found the similar findings in our study, and that both and their studies showed a significantly lower value in Schirmer's 1 value. And redness was the most common feature of the presenting feature. We would recommend that TFM instability can be easily detected and monitored by performing simple non-invasive testing of the TBO2 procedures and that of Schirmer's and 1 and TBO2 test, and should be performed for the patients of diabetic patients in routine OPD.
Thank you, doctor.
TFM instability was present in both the diabetic patients.
Now, how do you correlate
the P value of was more significant in diabetic patients than the non-diabetic.
How do you quantify that and compare?
We have compared diabetics with non-diabetics,
That's
but
right.
both of the patients were having pterygium.
With the pterygium and without pterygium.
Yeah, without pterygium.
Yeah.
And both showed instability, but the P value was more significant.
Now, what will be the cause for the instability of TFM in diabetics?
In diabetics?
Yeah, you said that.
It affects the TFM instability is more effective in diabetic patients.
Yeah.
That was the result.
What would have been the cause for that? Cause must also be known by them.
Causes that
Just
was,
diabetes, instability of the TFM?
that was an observation study. The causes
Okay.
were more.
Okay. The audience and get the, you can grasp the concept also very easily. Sometimes what I observe is because the time is so short, people start, firing the gates and ophthalmic fraternity present here. Good afternoon to everyone. The topic of my presentation is old is gold, but new is the sinew, role of OCT in glaucoma follow-up. Introduction, why this study? This is very evident that the problem is a gigantic one. According to the Glaucoma Society of India, the data regarding glaucoma prevalence in India is about 12 million AD. What exaggerates the problem is that the ophthalmologist per million population in India is very low, that is 9. So, and even more so that this is an iceberg phenomena, because the rate of undiagnosed glaucoma case, 45% of those diagnosed to have glaucoma had undergone an ophthalmic evaluation in the past itself. So the grave scenario of glaucoma as depicted makes it pertinent to diagnose and monitor progression with greater vigilance. Applanation tonometry, visual field analysis, gonioscopy, and optic disc examination remain the gold standards of glaucoma diagnosis. They are mandatory and not being challenged in any respect. But we need to just introduce some modality which is non-invasive, time efficient, and patient compliant. Recent studies have proven that OCT provides high resolution, objective and quantitative measurements of the optic disc parameters and RNFL thickness, and have been widely used for detection of glaucomatous damage and disease progression. In glaucoma, analysis of nerve fiber layer is gaining more and more significance because losses in this layer often precedes optic nerve changes. So we conducted this study to evaluate the UV treatment. New angle closure cases presenting during the study period were taken. Cases with media clarity interfered with proper documentation were excluded, and those who do not conform to the minimum follow-up duration were excluded from the study. Snellen's visual activities, slit lamp examination, applanation tonometry, automated perimetry, gonioscopy, fundoscopy, ultrasound, pachymetry, and these results were compared with the OCT evaluation of anterior segment,
and the disc RNFL and GCC changes. In tachymetry readings, no significant difference was found between the ultrasonic tachymetry and the OCT tachymetry that we did. P-value was 0.97. The average readings were 504.39 with the OCT and 504.59 with the ultrasonic method. In CD ratio, there was a bit overestimation with OCT, but still RNFL changes corroborated with the perimetric results, and this corroborated with the results that have been published in Glaucoma Journal 2012, in a study run by Wheat and Rangaswamy et al. GCC had been detection and documentation of the progression of the disease, and goniometry, while angle measurements are similar to the gonioscopic findings when compared. Other uses that OCT afforded was like tear film heights could be measured, which was very relevant because glaucoma medications generally cause dryness, and we could at a single sitting just measure the tear film height as well, and follow up of angles in post-laser albectomy could be done. So OCT proves to be a non-invasive, documentable and time-efficient tool. Tachymetry readings are reliable. RNFL evaluations corroborate with perimetric findings. CD ratio is overestimated, but this should be taken as a blessing in disguise, that it will prompt more intensive approach to exclude glaucoma. Because mostly when in medical colleges, mostly the patients are being seen, when seen by residents, they tend to go for the CD ratios as a marker, which is not very reliable, but still that is what prompts them to look for glaucoma. So if the CD ratio is overestimated, there would be a more intensive approach to excluding glaucoma. So in the end, what I would like to say is that we shouldn't be underestimating the power of the common methods. They are the pillars of strength, but at the same time we need to appreciate and incorporate what the newer methods have to offer. So it should be a cumulative effort of the man and the machine to cut the curse of glaucoma. Thank you.
Time domain, the other one is the spectral domain. The time domain machines are still available at a lower rate, but what my suggestion to the beginners or people who want to invest is, it's better to wait for the spectral domain OCT, which gives you a much better resolution and much wider field to choose, even though the cost is going to be greater. No doubt we need to have all the basic tests like appellation, gonioscopy and all that, apart from OCT. Thank you.
What does it mean? The sinew is for muscle. So the newer technology is meant to add muscle to the what old has already offered to us. So it provides strength to the diagnosis and the documentation of the progression of the disease.
Anyway, that's a very interesting title, and Dr. Ganesh here and I were examiners together for MD and DNB more than once. Among the first half of the papers, Dr. Nirupama Kasturi is not here yet, and then Dr. Aditi Dubey also is not here. And then we go on to the next paper, causes of failure and success of repeated external deck use to rhinostomy with intubation. Presenting author is Dr.
My study topic is causes of failure and success of repeat external DCRs with interest. DCR is a most commonly performed lacrimal surgery by any oculoplastic surgeon in practice, and results are gratifying in terms of relief of epiphora and discharge. Till now, the external DCR is considered the gold standard in primary cases with success rate of 90 to 100%, but in cases of reported from 50 to 100%. And if we use the bicanalicular silicone tubing, then it further increases the rate of success in these patients. The aim of the study was to evaluate the causes of failure and success of repeat DCR with bicanalicular laser intubation. 42 eyes of the recurrent electrostatic patients were reviewed retrospectively who went repeat external DCR with bicanalicular laser intubation from the period of September 2010 to December 2012. Patients are evaluated for the cause, time to recurrence, time to revision, duration of follow-up, and surgical success. Coming to demography, the male-female ratio was 2.8:1. Mean age was 35.5 plus minus 12 years. And there were equal right and left eyes in the cases that we studied. And the results of syringing before the repeat DCR was done, in 28 cases out of the 42, there was an LT block, and in 14 cases there was a common canalicular block. So the results, when we intraoperatively find out the cause, we saw that in most of the patients, that is around 90.4% patients, the cause of the failure that was implicated was granulation tissue, and the insufficient window was detected intraoperatively. We got nasal septal deviation in 3 patients, that is around 7.1%, and there was polyp in 1 patient. It was not done in a same setting, it was referred to ENT specialist. The polypectomy was done, and later on we did the DCR. These are the photographs of our patient. You can see the granulation tissue, small bony window in the second one, and polyp in the third. Then what we see, the median duration of recurrence, what we saw in the patients were around 6 months, ranging from 1 to 60. Median time for repeat DCR was from 8 months, and mean follow-up what we got was around 8 months, 7.53 plus minus 3.97 months. So in results we see that patent ostium plus relief of symptom were considered as a successful outcome. So in 88% patients we got the anatomic success, that is the patency of the ostium. But for subjective success, we did the month scoring, and grade 0 and 1 were taken as a positive results, and 83% patients were showing the positive results in terms of subjective success. And in failed cases, we had 5 failed cases out of the 42 eyes, in which 3 were common canalicular block and 2 were an LP block. So the rates of failure after the primary DCR surgery were reported in literature between 0 to 23%, which is very well compared with the study what we did. And then the revision external DCR can be performed in cases of external DCR recurring following the primary operations. In recurring patients, the success rates were reported between 85 and 92%. In the other studies, the references are given below. That is also comparable to our study. So I can conclude that repeat external DCR with bicanalicular nasal intubation can be recommended for recurrent acrocystitis as satisfactory surgical approach for objective and subjective success. Thank you.
Thank you, Doctor. There is no financial interest in this presentation. As you know, the principle of IL master, it's based on partial coherence interferometry.
Get closer to the mic.
Yes, sorry.
Yeah.
To measure the axial length of the globe. This is a photograph of the IL master. Principle of A scan is based on 3 basic principles, as you know. The resolution is directly linked to the wavelength. The accuracy of a measuring instrument is an inherent photograph of A scan. There are few limitations. One is variable corneal compression. Second is broad sound beam. Third is limited resolution. Incorrect assumptions regarding sound velocity and potential for incorrect measurement distance. This is an ultrasound display of different echo spikes. C1 and C2 are the anterior and posterior corneal surfaces, as you can see, and L1 and L2 the anterior and posterior lens surfaces. A scan being performed by the optometrist. There is a principle of reflectivity. When the sound beam encounters the interface of a substance that is dissimilar from the substance it is travelling through, part of the sound beam energy is reflected and part of the sound beam energy projects through the new substance. The more dissimilar the substances are, the stronger the reflection or echo is. So the purpose of a study was to compare the accuracy of IL master and A-scan biometry. It was a retrospective single center study, 91 eyes of 90 patients, performed in April 2013. Axial length was measured preoperatively with both the instruments. Intraocular lens power was based on SRKT formula. And patients underwent refraction 1 month post-operatively to check for refractive error. Only spherical component was taken into consideration for comparison. Exclusion criterion was that whenever all those patients in which IL master was not possible were excluded from the analysis. Our results, IL master was found to be more accurate than A-scan biometry in 59.34% eyes, equally accurate in 23.07% eyes, and less accurate in 17.58% eyes. This is the diagrammatic representation of the data. and a histogram showing the difference in the accuracy between the two instruments. So the refractive error was present in 28.57% eyes on which IOL master was performed. 15.38% had a 0.50 diopter refractive error, 8.79% had 1 diopter error, 3.29% had a 0.75 diopter error, and 1.09% 1.5 diopter error. The results of the refractive error in IOL master shown in the form of this diagrammatic representation as a bar chart. And we searched the literature, and there was another study in which by the Chinese team of doctors, which was published, and they also compared the anterior chamber depth in their patients. This is the scatter plot of their study and scatter plot of our study. So conclusion is that IOL master provides both provide accurate values, and IOL master not only has the advantage of performing non-contact examinations, but also simultaneously you get other data without any need for multiple examinations. But further studies are needed to assess the interchangeability of measurements in clinical practice. So the conclusion in our study is that IOL master was found to be more accurate than A-scan biometry. I dedicate this presentation to my father, who dedicated his life for the medical profession and unfortunately passed away last year in April 2013. I thank the scientific committee and the respected panel for giving me this opportunity to present at the AIOC 2014. Thank you very much.
Thank you, Dr. Sunil.
One is the cost factor for private practitioner. The second one is the density of the case. Some of the, though NIDEC, ZACE, all these companies do come, there are limitations as far as the density of the cataracts are concerned. Certain cataracts we are not able to. Immersion we can adopt in such cases.
Thank you very much. Thank you.
I think they are now going to integrate both the scan and the master together. Some of the companies are trying it.
A pilot study. Dr. Virendra Sachdeva from Visakhapatnam.
Good afternoon, everyone, respected guys and my friends. I shall be presenting the results of this study titled as Combined Occlusion and Ectopine Therapy for Children with Refractory Amblyopia. It was a pilot study. We don't have any financial disclosure. Well, we all know that either patching or penalization has been the first-line treatment for the patients with amblyopia, and there is a good reported success rate in the literature. But about 20% of the patients on an average may still have a best corrected visual of less than 20/30, and about 18% of the patients are reported to have a refractory course to the treatment despite good compliance. So what do we do in these cases? We reconsider the diagnosis whether we have missed something, or if it's still amblyopia is our diagnosis. The options are either we discontinue the treatment, we continue the treatment at the same rate, or we intensify the treatment. And keeping in view that the child has a long life to go, we all of us like to intensify the treatment. So what are the options? Like if it's a part-time patching, you change to full-time patching or increase the patching hours, switch to alternative therapies like maybe try penalization with glasses or with ectopine refractory cases, and they have tried combined optical as well as ectopine penalization, and they have reported good results. There is a vision trial which is conducted by the PD group, and they have shown that when they increase the number of patching hours in moderate amblyopia from 2 hours to 6 hours, a majority of the patients had a greater level of best corrected visual acuity improvement as compared to the group when they continued the patching at the same rate. However, despite this, there is a problem of disturbing the schooling hours, increased difficulty with the emotional impact, and that compliance will be a question in these cases. So we thought of trying addition of ectopine to occlusion therapy in these children, and with this we designed a prospective non-randomized, non-comparative case series because it's a difficult population to get. These are less common cases. The study was conducted at UPI Visakhapatnam campus. We included children who were 4 to 11 years of age. They were compliant to amblyopia therapy, and they were either refractory or had a residual amblyopia. I'll define them later. And we excluded patients who had coexisting nystagmus, patients who were uncooperative, and parents who were unwilling to give the consent. So refractory amblyops were defined as those who did not have any improvement from the baseline more than greater than 1 line. So the BCVA did not improve more than 1 line despite compliant therapy. And residual MLabs were defined as those in whom the improvement was more than 1 line, but it still stopped less than 20/40, and there was still a difference in the restricted visibility between the 2 eyes of more than 2 lines. All these patients were given combined therapy with daily part-time patching as well as twice a week atropine administered at bedtime on Wednesday and Saturday. The patients are followed up every 2 months, and we look for the improvement in the best-corrected visual acuity. Appropriate statistical analysis was done. It was a non-parametric data, so appropriate tests were used. Coming to the results, we found 23 children who were enrolled during this period. The mean age was 5.2 years. There was no gender bias, and despite the fact that majority of patients were asymptomatic MLabs, there were a few statistical MLabs and few stimulus deprivation MLabs. Majority of the patients had moderate and severe amblyopia. This picture shows the improvement in the best-corrected visual acuity. The first shows the best-corrected visual acuity prior to patching was about 2200 or 1.0 logMAR, and it improved after patching to about 0.8 or 20/160, but it stopped there. After 3 months of additional core therapy, the visual acuity improved to 0.67, and after continued therapy, it improved to about 0.5, that is about 20/40 in majority of the patients. This shows the improvement in the best-corrected visual acuity, and there was improvement at 6 months by 2 logMAR lines, and at about in the last one, which was about 1 year, it was about 3 logMAR lines. This shows the distribution of visual acuity. If you look here, none of the patients had a visual acuity better than 20/30 despite compliant patching therapy, and about 22% got a visual acuity better than 20/30. Another 22% got a best-corrected visual acuity between 20/30 and 20/50, and only 40% had a base amblyopia still. Coming back, there were no other factors which affected the results, and very few complications were observed, such as fever in one patient and blurring of near vision temporarily in one patient. So these are the studies which have looked at the other options, and the ATS11 looked at the same question which we looked in our study, but they did not find any additional benefit. But in our study we got good benefit, and this was possibly because in the ATS11 they looked at the improvement only at 10 weeks. Whereas in our study we found that prolonged treatment at 6 months and even at 1 year they led to continuous improvement. So maybe prolonged treatment may be helpful, that is important. There were limitations like small sample size because of difficulty in finding these patients in a comparative non-randomized study. But as of now, maybe we can look at this in the way that combined occlusion and atropine therapy may be useful. The better compliance may be expected, then increased patching hours, and further randomized control trials are needed to help.
Can you conclude with the next study? Thank you.
Yes, the child was about 10 years of age.
How much improvement did we get?
I don't remember the exact patient detail, but don't improve so much are the ones who have a stimulus deprivation. They are more densely amblyopic rather than the age.
Yes, that is one.
Can we...
Second were the strabismic amblyops.
See, we can give the benefit of doubt and we can continue the treatment. If the person is, we recognize amblyopia at the age of 8 plus. Is it not?
Definitely. Maybe up till the age of 13 years, PD has also shown if no treatment has been given, definitely we should give. 13 to 17 years, if no treatment was given or the patient was non-compliant initially, then definitely it's
and that differs from the old
old concept.
Thank you, Dr.
According to recent survey of WHO, 75% of blindness in children is curable or preventable. In Indian scenario, school-going children account for more than 25% of the population. In every year, 50,000 will become blind, mainly due to malnutrition, cataracts, illiteracy, particularly in parents, and difficulty in access to the eye care facilities. 70 to 80% of children are out of reach for half the month. Most important thing is restoration of vision in one child is equal to giving vision in 10 adults. Aim of study is to evaluate post-operative visual outcome. Material methods are a prospective study conducted with 10. Number of cases 73, number of sites 103. Inclusion criteria: children above 5 years are included with visual acuity at least PR and PR. Both blind school children and walk-in patients are included. Exclusion criteria: children below 5 years are excluded from this study. Vision: if the eye is no PR, excluded this study. Eyes with positive sequence pathology are excluded from this study. Evaluation done with anti-segment evaluation is slit lamp biomicroscopy. Both direct and indirect options will be done. On the disc evaluation done with 70-80. When there is a thick clavicular opacity, this can be used for posterior segment evaluation. Parents also examined for consumption. Urine for reducing sugars, amino acids, and blood glucose, hemoglobin done. Wherever necessary, pediatric evaluation done by pediatrician. The child with bilateral thick unilateral cataract. Surgical procedure done, SIC is done in all cases, and capsulotomy, canoplar, capsulorhexis, both techniques are used. Single lens, PMME lens placed in these eyes. Sutures applied in children less than 8 years old. Post-operative evaluation done with slit lamp evaluation and antibiotic steroid drops and mediated prescribed. Results: 78.1% are males in the study and 21.9% females. And age distribution is 54.5% in 5 to 10 years of age and 45.4% 11 to 15 years. Nystagmus is present in 40% of the cases, especially in bilateral cases. Type of the cataract is neglected cataract, that is cataract not operated at proper time, that is 60% in this area, and developmental cataract 28%, 12% of traumatic cases. Post-operative visual outcomes, 63% of cases only counter fingers close to the face to 660 we got, and 26% 624 by 636. Only 11% of cases got 618 to 69. Complications, most common complications 43% is posterior capsular opacification, developed in 6 to 7 months. 21% of cases hydrocyclitis, 50% of cases glaucoma. In our study, rate of cataract was higher in boys, that is accounted to 78.1%, when compared to girls, that is 21.9%. 40% of cases are associated with nystagmus, that indicates early onset of lens opacity. In our study, visual prognosis is good in children with laminar posterior subcapsular cataract and eyes with good fixation. Poor visual outcome was noted in children with nystagmus and those with unilateral congenital cataracts. Most important concern is presence of congenital cataract even after 5 years of age. Hence, examination by a qualified ophthalmologist should be made a part of screening of newborn child, along with increased awareness among pediatricians regarding congenital cataract. Conclusion: in spite of advanced technology at the disposal of an ophthalmologist, management of childhood cataract poses a significant challenge. Every child with cataract should be operated. Presence of significant number of children over 5 years of age with congenital cataract suggests that importance of strengthening of primary eye care that helps in early diagnosis and management. School eye screening should be included in a routine practice in all schools. Children in blind schools should be evaluated in order not to miss those blind due to the cataract. Other studies are data 2001 that they included 0 to 11 years of age. Take home message is no child should be left with cataract. Even if child visual acuity is counting fingers close to the face, patients are greatly benefited with cataract surgery. Thank you.
Thank you, Dr. Rao. Along the statistics, no matter what the statistics are, please see the total comes to 100.
So that the rate was higher in boys is maybe just a presentation difference. Boys have been brought more commonly towards rather than.
Because it's trained blind schools also. In blind schools, generally boys are more in blind schools.
Thank you, doctor. We go to the next paper.
Good afternoon, everybody. I'm presenting a paper on clinical spectrum and visual outcome of Wondt-Chiari-Harada disease in a tertiary care center in central India. BKH syndrome is an uncommon multisystem disease of presumed autoimmune etiology. It is characterized by chronic, bilateral, dermatologic, neurologic and auditory involvement. The aim of the study was to report the clinical spectrum and the visual outcome of BKH disease in central India. It was a retrospective case series wherein the medical records of 14 patients, 20 eyes diagnosed with BKH disease presenting between January 12 and April 13 were reviewed. The materials and methods included: all the patients were evaluated for the clinical presentation and systemic manifestations. Thorough evaluation of the anterior segment with slit lamp biomicroscopy was done. FFA and serial OCTs were documented. The pre-treatment and the post-treatment best corrected visual acuity was documented. The mainstay of treatment was the systemic steroids. The mean follow-up was recorded and the complications were documented. Coming to the results, of the 14 total patients, that is 20 eyes, 9 were males and 6 were females. The mean age of presentation was 37.6 plus minus 14.27 years. The systemic manifestations were seen only in 4 patients, the neurological being 3, that is tinnitus in 1 and meningismus in 2, and integumentary manifestations were seen only in 1 patient, that is poliosis. The most frequent complaint at the presentation was transiently blurred vision, immediately followed by rapid decrease in vision in 75% in one or both the eyes. The other complaints included red eyes, orbital pain and floaters. Red eyes again being in 75% of the cases, floaters in 1 out of 20, orbital pain in 6 out of 20 cases. Both the eyes were affected simultaneously in 40% of the eyes. In the remaining patients, the interval of the uniocular to the binocular involvement ranged from 1 to 15 days, and the duration of initial symptoms to the presentation was almost 15 days to 1 month. The ocular manifestations were bilateral anterior uveitis to panuveitis. Anterior segment inflammation was present in 15 out of 20, that is 75% of the cases. KPs and AC reaction were both in 75% of the cases. Posterior synechiae and fistulum pupil were seen in 60% of the cases, and panuveitis in 20% of the eyes. Coming to the lenticular status, it was clear in 70% cases, 5% cases it was pseudophakic, and complicated cataract was seen in almost 25% cases. The posterior segment manifestations, the most common manifestation was serous detachment in all the eyes, 60% bilateral. Disc edema was seen in 50% of the cases, and vitritis in 30% of the cases. Choroidal detachment was seen in 10% of the eyes. The late ocular manifestations showing the sunset globe fundi, nubular polyoretinal depigmented scars, the retinal pigment clumping or migration was seen in almost 25% of the cases. FFA revealed early pinpoint hyperfluorescent spots to the rate leakage in the subretinal space with SRF pockets were seen in OCT. Mean pre and the post-treatment RCs on B scan were 2.26 plus minus 0.98 and 1.49 plus minus 0.45. This is the pre and the post-treatment OCT showing the resolution of the SRF in VKH. The mainstay of the treatment was systemic steroids, with 75% of the eyes requiring IV dexamethasone therapy and additional immunosuppression. The mean follow-up was 10.4 months plus minus 3.55. Visual acuity at presentation was logMAR 1.77 plus minus 1.02 and post-treatment was 0.5 plus minus 0.66, which was visually significant, statistically significant. Coming to complications, 2 eyes developed complicated cataract, 1 developed glaucoma and 1 CME. Starting with the discussion, VKH is a sight-threatening disorder of autoimmune etiology. Early recognition and suppression of inflammation is essential to preserve the vision in this chronic disease. Most common presentation being the serous retinal detachment in 100% cases in RCDs, high-dose oral corticosteroids, that is IV dexamethasone, gradual tapering of the dose according to the clinical response are the mainstay of the therapy. Treatment has to be usually required for 6 to 9 months. Additional immunosuppression is essential in maintaining long-term stability in the visual outcomes. In our cases, 8 cases of unilateral present. No incidence of reoccurrence of the symptoms, involvement of the other eye was noted during the follow-up period. And concluding the session saying that VKH presents with a wide spectrum starting from anterior to panuveitis, most common being serous detachment, steroids are the mainstay of treatment, and long-term follow-up with immunosuppression improves the anatomic and functional outcome. Thank you.
I am presenting a case of supratemporal branch retinal vein occlusion in patient of tuberous sclerosis. Author and co-authors have no financial interest. Tuberous sclerosis classically presents adenoma sebaceum. Among the ocular manifestations are astrocytic hematoma in retina. Retinal astrocytic hematoma are usually located in the inner layer of retina or optic disc, obscuring the retinal vessels. Purpose is to report unusual case of supratemporal branch retinal vein occlusion in patient of tuberous sclerosis. 26-year male presented with chief complaint of floater in left eye for 3 days, which were not associated with any decrease in vision, flashes, red eye, eye pain or watering. Patient has history of epilepsy once in childhood, for which he had consulted neurophysician, and tablet Aptoin 100 mg 3 times a day was given by neurophysician and advised MRI. But MRI was not done by patient and patient lost follow-up. Electrolysis was done once for facial lesion by dermatologist. Base corrected visual acuity in both eyes were 6.6 with minus 4.25 diopteric spherical and minus 0.5 diopteric cylinder at 70 degree. Slit-up examination revealed no abnormality. Cover test revealed orthophoria. Eye movements were full, free and painless in both eyes. Binocular indirect ophthalmoscopic examination revealed yellowish white mulberry-like growth and whitish calcified patches in infratemporal quadrant in right eye. Type 1 lesions usually occur as a circular or oval-shaped solitary lesion with an average size of 0.5 disc diameter. They are relatively flat, semi-transparent, soft, light grey, glistening mass lies in the retinal nerve fiber layer without signs of calcification. The most common type 2 lesions are prominent with multiple calcified nodular areas of variable size arising from the inner surface of retina. These well-circumscribed multinodular lesions are characteristically found at the posterior pole where they resemble drusen of optic disc and are described as having appearance of mulberry-like. Binocular indirect ophthalmoscopic examination of left eye revealed diffuse vitreous hemorrhage and yellowish white mulberry-like growth in supranasal quadrant. Clinically, lesions were diagnosed as retinal astrocytoma. FFA shows staining of lesion but no leakage of dye in lake phase. Spectral luminosity through the lesion show hyperreflectivity of inner retinal layer with posterior shadowing. Patient was never diagnosed as having tuberous sclerosis complex before, so we have advice for systemic association and advice for imaging. Systemic examination show adenoma sebaceum, forehead plaques, dental enamel pit, S-leaf spot and periangular fibroma. Imaging show cardiac rhabdomyoma, renal angiomyolipoma and cortical tuber. We have advised the patient was kept under observation and we have advised the patient to sleep with 2 pillows and avoid any staining. After 2 months, patient came with resolving vitreous hemorrhage and supratemporal sclerosed vessel and NVE were seen. FFA demonstrated neovascularization with area of capillary non-perfusion in supratemporal quadrant and retinal astrocytoma show diffuse staining but no leakage of dye. So diagnosis of supratemporal branch retinal vein occlusion was made and sectoral PRP was given in supratemporal quadrant. Discussion. While most retinal astrocytic hematoma remain asymptomatic or gradually regress during life, some exceptional cases may develop subretinal exudation or even vitreous hemorrhage. Retinal astrocytoma can show progressive enlargement, retinal detachment and vitreous seeding, findings that can mislead the clinician towards the diagnosis of retinoblastoma or choroidal melanoma. So to conclude, vitreous hemorrhage due to sporadic retinal astrocytoma has been reported in literature. No case of retinal vein occlusion in patient with tuberous sclerosis has been reported so far. Symptomatic alteration in patient with tuberous sclerosis needs to be assessed carefully and treated accordingly. Thank you.
Thank you, doctor.
Sitting in the audience, what we observe, some of your pictures you have tried to fit in the frame, you are elongated, so the perspective has changed. Second, the colors that you have used for labeling those diagrams are not making it readable at the back. Fundus diagrams you have put in black. If you were to use white color for those, it would be more visible. The labeling is visible to you when you do on computer screen. But when you are projecting here in the hall, it is not visible, especially in a larger hall from the back. And lastly, you have been writing a lot of material on the slide as sentences. I would suggest you write what you need to present in points to take a cue, give them bullets and read those points instead of having an entire paragraph on the slide. That way, you can enlarge the diagram and have less written matter for the same slide. Okay. So if you do those things, presentation is good, but you will have to put a little less content on the slides and let us. So I just thought I would tell you also. Okay,
thank you. We come to the last. And Vito.
Good afternoon, everyone. I am here to present my study on comparison of past and vitrectomy with or without buckle for management of retinal detachment. So, author has no financial interest or applications. Leave the abnormal vitreoretinal traction and to reoppose the neurosensory retina either internally or externally. The various surgical options available are scleral buckling surgery, vitrectomy surgery, and combined procedures. When it comes to choice of the surgery for retinal detachment, controversy exists on superiority of a single method or use of combined surgical techniques. Various studies have shown that vitrectomy with or without scleral buckling is preferable in more complex pseudophakic RDs with multiple breaks and presence of PVR. But between the buccal vitrectomy surgery and non-buccal vitrectomy surgery, the anatomical and functional results are variable. So purpose of our study was to see the anatomical success rate between the combined pars plana vitrectomy and scleral buccal surgery and the pars plana vitrectomy alone, and hence to evaluate the improvement in visual acuity between the two groups. This was a retrospective study. Patients were included were rhegmatogenous retinal detachment which required surgical intervention, visual acuity, hand movement or better, absence of macular disease and age more than 18 years. Patient excluded were history of eye trauma, corneal or lenticular pathology, history of intraocular surgery except for cataract surgery, and presence of PVR of grade B or more. There were 20 patients in each group. Preoperatively, patients were evaluated with visual acuity, which was later Snellen's visual acuity, which was later converted into log MAR value. Surgeries were performed by single surgeon. Type of surgery was on surgeon's preference. In patients, 23G pars plana vitrectomy with wide-angle viewing system was done. Scleral buccal was applied in buccal vitrectomy surgery, which I will show you a small video of it. Silicone oil was used as internal tamponade. Post-operatively, patients were followed up for 2 months and 6 months. Retinal attachment was present or absent was noted, and visual acuity was also tested. There is a small video of how we put the buccal. We make a 4-quadrant tunnel. 240 number scleral band buccal was applied to one band with behind the posterior margin of the muscle insertion. This is the band. And it is tied at the superiotemporal quadrant at the end of the surgery. So we have observed 95% anatomical success rate at 6 months in buccal vitrectomy group as compared to 75% in pars plana vitrectomy group. At the 2-month follow-up, there were 70% of the patients who had anatomical success in PPV group. The 30% of the patient required second surgery for retinal redetachment. There was improvement in visual acuity from logMAR 1.35 plus or minus 0.09 to 0.72 plus or minus 0.01 post-operatively in patients with buccal vitrectomy. The improvement in visual acuity was also seen in patients who underwent pars plana vitrectomy alone for retinal detachment. At 2 months of follow-up, we see a drop in visual acuity that was because of the retinal redetachment. But the improvement in visual acuity at 6 months was statistically significant in buccal vitrectomy than non-buccal vitrectomy group. As we all know, to prevent the recurrent detachment, we have to prevent the missed breaks, new breaks and proliferative vitreoretinopathy. As various studies have shown, primary vitrectomy without scleral buckling provides a better anatomical success rate with an added advantage of reduced trauma to the conjunctiva with no scleral sutures and therefore reduced rehabilitation period. But the combined approach for scleral buccal vitrectomy is recommended by various studies in patients with phakic and pseudophakic retinal detachment. The rationale of using scleral buccal is to prevent recurrent retinal detachment from new breaks, unseen breaks, inferior breaks. It also relieves the anterior traction on the vitreous base. So among the studies comparing the two procedures for retinal detachment, results are variable. So to conclude, in agreement with the study performed by Desai et al., we have observed a better anatomical results in combined group compared to a pars plana vitrectomy group. In contrast to other studies, there is a statistically significant improvement in visual acuity in combined group as compared to pars plana vitrectomy group. So it appears that combined approach is superior to pars plana alone in management of retinal detachment, at least in the initial period. But the limitation of our study was it was a retrospective study, non-randomized study, and visual acuity was tested on Snellen's chart and smaller sample size and shorter follow-up period. Thank you.
By youngsters, and all of them have done very well. And though it's a little late, and I thank the interest shown by the few audience that here who are still not sleeping. And it's time for lunch, and I thank Dr. Ganesh who was with me, and thank you very much. I thank the projectionists as well as the